Thank you for joining us for our Time for Genetics webinar. Today's topic is on Ehlers-Danlos Syndrome, and we are excited to welcome Dr. Elias as our guest speaker. I want to acknowledge our HRSA funding statement. Mountain States Regional Genetics Network is supported by a grant from the Health Resources and Services Administration, and there's more details here on this slide. I'd like to introduce myself. My name is Christy Weiss. I'm the projects manager for Mountain States Regional Genetics Network. And also joining us today is Cody Price, our state teams coordinator. We're here in the background to help with any technical issues and logistics. Speaking of logistics, these are some Zoom logistics for everyone. Just some notes for everyone to take a look at the bottom of your screen. Number one is the mute unmute button. We are asking everyone that is attending to stay in mute during the webinar. You are free to, at number 2 there on the slide, to turn your camera on if you feel comfortable. We are recording this for archival purposes, so please keep that in mind, that your image may be recorded if you turn your camera on. Number 3, you can see the participants list, and number 4, you can see the chat box. And we will be using the chat feature for Q&A or technical issues, so please feel free to submit your questions there as you watch the webinar. This is part of our Time for Genetics series. Our Time for Genetics initiative is a pediatric primary care genetics education initiative that we launched in 2020. In our Mountain States region. Our first cohort of clinics are the 7 yellow specks on the map there, denoted there. And we are so happy to have them joining us today, as well as everyone else who's interested in this topic. We are very excited because we currently have our application open until this Monday for cohort number 2 of our Time for Genetics program. This is a free program. And it does not cost the clinic anything. So if you or someone you know may be interested in participating as part of this cohort number 2, we ask that you let them know very soon before Monday, and they can complete a short, less than 5-minute application to apply for that program. This slide here has a QR code that will take you directly to that application. And again, that is due this Monday. We still have spots open in many of our states for clinics to join us. We are having this webinar with continuing medical education. This is provided through Projects in Knowledge and is a jointly accredited event. And today's webinar has been pre-approved for the following types of continuing education credit: CME for physicians, PA-CME for physician assistants, CNE for nurses, and CPE for pharmacists. We will be sharing information at the end about how to claim your CME and CEU credits, so stay tuned for that. With that, Dr. Elias, our speaker today, has nothing to disclose for this presentation. I'd like to now introduce our speaker, Dr. Elias. Dr. Elias joined Shodair Children's Hospital in 2013 and became the medical director of the Department of Medical Genetics in June 2014. He is board certified in clinical genetics and family medicine and trained in pediatrics at the University of Freiburg, Germany. He completed a residency and fellowship in clinical genetics at the McKusick-Nathans Institute of Genetic Medicine, Johns Hopkins University School of Medicine, where he was the recipient of the Margaret Ellen Nielsen Fellowship Award in Genetics Medicine. With that, we are excited to have him talk to us today on the topic, what do you do when you suspect Ehlers-Danlos Syndrome? A practical guide. With that, I will stop sharing my screen and turn it over to you, Dr. Elias.
Hi, my name is Elias, and I welcome you to today's webinar, What to Do When You Suspect Ehlers-Danlos Syndrome, a Practical Guide. If you are a pediatrician or otherwise involved in pediatric healthcare and are seeking information on how to take care of children with hypermobility, this webinar on hypermobile Ehlers-Danlos syndrome was developed through the Mountain States Regional Genetics Network with you, that is the primary care provider, in mind. This webinar follows the general outline of the companion document with the same title, which can be downloaded on the MSRGN website. It is a resource for pediatric healthcare providers, and its focus is joint hypermobility syndrome, hypermobile Ehlers-Danlos syndrome, or also called hypermobility EDS. Although we will mention other forms of EDS and related connective tissue disorders, for example, when discussing differential diagnosis, these conditions will not be reviewed in detail here. And a PDF version of this guide is available on the MSRGN website together with other resources. Just Google MSRGN and you should be able to find it. I do want to mention that this project was supported by a HRSA grant. And then let's get started. So the cardinal symptom or sign of EDS is joint hypermobility. Let's talk about joint hypermobility first. It seems simple enough to define hypermobility as more than normal range of movement, either in a single joint or generalized. However, it's not always straightforward, indeed, to get a consensus on the presence of hypermobility, and there's wide variability, but the prevalence of asymptomatic joint hypermobility in children is actually quite high and maybe more than 30%. Generalized joint hypermobility in the general population is estimated to affect 10 to up to perhaps 20%. And most cases of joint hypermobility you see in your clinic will be an isolated phenomenon, defined as asymptomatic hypermobility. I'd like to clarify a few points on the terminology we will use here. As mentioned, joint hypermobility is more than the normal range of movement, and we will learn what more than normal means. We also distinguish between asymptomatic versus symptomatic joint hypermobility. And then there is our topic for today, and that's Ehlers-Danlos syndrome. And I intentionally will use several terms interchangeably, acknowledging that opinions differ among experts, with some being lumpers and some being splitters. And a discussion of this ongoing debate is beyond the scope of this webinar, but it's appropriate to use these terms interchangeably in our context. These terms include joint hypermobility syndrome, Ehlers-Danlos syndrome hypermobility type, hypermobile Ehlers-Danlos syndrome. In the past, there was also type 3 EDS, but that term is not used anymore on a regular basis. We will refer to rare heritable diseases of the connective tissue as an umbrella for several conditions, including non-hypermobility type EDS, and 13 of the 14 described so far are molecularly defined. That includes classic type, vascular type, arthrochalasia type, dermatosparaxis type, and kyphoscoliosis type, and several others. All of these are quite rare, and we will not go into detail here, but it's important to mention them. Another syndrome that's under this umbrella is Marfan syndrome that many of you might be familiar with, and the related condition, Loeys-Dietz syndrome, also congenital contractorial appendectomy, for example. So joint hypermobility is commonly observed in clinic as an isolated phenomenon, defined as asymptomatic hypermobility. Less frequently, joint hypermobility is associated with musculoskeletal symptoms such as arthralgia, chronic regional pain, premature arthritis, and then may be labeled as symptomatic joint hypermobility. Even less frequently, symptomatic joint hypermobility that is generalized presents with persistent musculoskeletal symptoms, is associated with extra-articular manifestations such as mild abnormalities of the skin, and meets certain diagnostic criteria, may be defined as joint hypermobility syndrome or hypermobile Ehlers-Danlos syndrome. And rarely, patients with joint hypermobility may have Mendelian disorders of the connective tissue, which I just earlier referred to as heritable diseases of connective tissue, which includes, just as a reminder, the heterogeneous group of non-hypermobility type EDS, Marfan syndrome, Loeys-Dietz syndrome, and congenital contractorial acrodactyly. Generalized hypermobility can be a feature of several other disorders that do not involve connective tissue, such as neuromuscular disorders, gastrointestinal disorders, immunological disorders, and chronic pain syndromes. A few words about genetic testing. The scope of this practical guide is joint hypermobility syndrome or hypermobile Ehlers-Danlos syndrome. There's currently no genetic test available for hypermobile EDS, and the diagnosis is made clinically. Genetic testing is available for the 13 other of the 14 types of EDS, and it plays an increasing role in the classification and diagnosis of heritable connective tissue disorders. Genetic testing will be recommended if indicated by findings of on the physical exam, medical history, or family history. Genetic testing ideally is also initiated in collaboration with a healthcare professional who's versed in the diagnosis of heritable connective tissue disorders, and genetic counseling should be provided if genetic testing is pursued. So this algorithm, we will come back frequently, and it's at the core of our guide. We will use it as a scaffolding that allows us to move along to achieve a diagnosis and think about our management. We start with the assessment of joint hypermobility. So hypermobility is best assessed using a goniometer according to the Beighton scoring system. And there's one here, and you all have seen it, I'm sure, but not everybody might use it. Not everyone might use it on a regular basis. But a goniometer can measure the angle between two segments of a joint. And the term actually derives from the Greek gonia, which means both angle but also joint. Here we see the Beighton scoring system for hypermobility. Each joint is measured using a goniometer, as I just showed, and each side is scored independently. Number one, the passive apposition of the thumb to the flexor aspect of the forearm, and you get 1 point for each hand. Number two, the passive dorsiflexion of the fifth finger beyond 90 degrees, and again 1 point for each hand. Number three, hyperextension of the elbow beyond 10 degrees, and again 1 point for each arm. And then number four, hyperextension of the knees beyond 10 degree, and again 1 point for each leg. And then at the end, the forward flexion of the trunk with the knees extended and the palms should be resting comfortably on the floor. So we can get 2 points for each side, and 1 point for the forward flexion of the trunk, which adds up to a maximal Beighton score of 9. I would recommend having the patient change into a gown, or making sure you can access the anatomical landmarks of all extremities, which can be especially difficult for the lower extremities when the patient, for example, wears tight-fitting pants. So in the following slides, we will review how to measure joint hypermobility or joint mobility and obtain a Beighton score correctly. The photos I will be showing are from the Smits, Engelmann, and co-authors 2011 paper in the Journal of Pediatrics that validated the Beighton score as a measure for generalized hypermobility in children. So this first one, the passive apposition of the thumb to the flexor aspect of the forearm, might be the most difficult to correctly interpret. The passive movement must be in the carpometacarpal joint. which is between the first metacarpal of the thumb and the trapezium carpal bone. The movement essentially assesses the mobility of the wrist. So this is not a movement in the MCP joint of the thumb as shown on the right. Now, with the dorsiflexion of the fifth finger, we do assess the mobility in the MCP joint of the fifth finger. The passive dorsiflexion of the fifth finger beyond 90 degrees indicates hypermobility, and that results in 1 point for each side. When you assess extension in the elbow, it is important to use the correct anatomical landmark. So place the goniometer over the lateral epicondyle, and then proximately it points to the tuberculum majus, or the major tuberculum of the caput humeri. Distally, it points to the processus styloideus, or styloid process of the radius. And hyperextension of the elbow I'm sorry, beyond 10 degrees is an indicator for hypermobility, and it adds 1 point to the score for each side. Similarly, you want to identify the correct anatomical landmarks when assessing extensibility in the knee joints. Here, it is especially important that you can assess the entire lower extremity. As mentioned earlier, having the patient change into a gown prior to exam may facilitate the hypermobility exam. So you place the goniometer over the lateral femoral condyle, and proximally it points to the trochanter major or major trochanter. Distally, it points to the lateral malleolus of the fibula. And then again, you obtain 1 point for each side. Here then is shown the forward flexion of the trunk, and as you can see, it is important that the knees are fully extended and the palms rest comfortably flat on the floor to obtain a point as shown on the left side, whereas the right side, the right photo would be negative. But here you only have 1 point to give. So now that we completed the exam, we add the points for each joint, and the sum represents the Beighton hypermobility score. Again, there are a maximum of 12 points for each pair of joints in the extremities, as summarized in the table. And then there's 1 point for the forward flexion of the trunk. The maximal Beighton score is then 9. And a positive Beighton score is somewhat age-dependent. There is some variability in the literature, but reasonable cutoffs are shown here. So in prepubertal children, the cutoff is 6. This accounts not only for the high prevalence of asymptomatic hypermobility in children, as previously mentioned, but also for a slight variation in the exam in preschoolers, which we will review here soon. In adolescents and adults, the cutoff is 5. And as we age, our joints are becoming less flexible, even in individuals with hypermobility, which is why in adults older than 40 or 50 years old, a Beighton score of 4 may already indicate hypermobility. So I think that these considerations also speak to the limitations of the Beighton score, especially with regard to variability due to age, individual constitution, and patterns of hypermobility. And we will come back to this aspect later in this webinar. So here's a question for you. Is the Beighton score valid in children? And the answer is yes. The Beighton score, when used correctly, is a valid instrument to measure generalized joint hypermobility in school-aged children 6 to 12 years old. And there's no extra items needed to improve the scale. And this was established in the paper I previously mentioned by Smits-Engelmann, published in the Journal of Pediatrics in 2011. In contrast, and that's worth maybe to mention here, pain over a period of time or after exercise, for example, does not add valid information to hypermobility related complaints in children under age 13. So the hypermobility in this age group, to remind you, defined by a Beighton score of 6 out of 9, was not predictive of future musculoskeletal pain in preteen and adolescent children. And that was published by Elmet Wally in BMC Musculoskeletal Disorders in 2007. So what about preschool age children? In general, the Beighton score is a valid measure of joint hypermobility in this age group. However, the task of forward flexion is difficult for children younger than age 4 to really follow. And therefore, a modified Beighton score was proposed by Romeo et al. In a paper in the Journal of Pediatrics in 2016. In this modified Beighton score, the forward flexion is replaced by a passive dorsiflexion of the ankle joint bilaterally, as shown in this cartoon. The ankle dorsiflexion then is positive when the angle is greater than 30 degrees, and you do bilateral testing, so you get 1 point for each side. And because the maximum of 2 points for each ankle joint is compared to the 1 point for forward flexion, the total Beighton score in this scoring system increases then from 9 to 10. The cutoff then is adjusted to 6. So a positive modified Beighton score for preschool age children is 6 and greater. And as mentioned earlier, the Beighton score is not a perfect instrument for measuring hypermobility in all individuals. It's true that generalized joint hypermobility frequently prompts consideration of a heritable connective tissue disorder. However, hypermobility might not always be the presenting sign and may be mild or even absent in several important differential diagnoses of hypermobility EDS, including vascular EDS and Marfan syndrome. In vascular EDS, hypermobility is not generalized, but typically limited to the distal small joints and is usually not associated with dislocations or subluxations of large joints. In addition, distal joint hypermobility really represents only a minor diagnostic criterion of vascular EDS and might indeed be entirely absent. Similarly, joint hypermobility is not part of the systemic score in the revised Ghent criteria for Marfan syndrome. In contrast, a positive wrist and thumb sign in patients with Marfan syndrome may reflect dolichostenomelia, meaning long limbs, rather than hyperextensibility of joints and ligaments, and may be associated with a reduced extensibility in the elbow, which is actually a criterion in the systemic Marfan score. And lastly, the Beighton score may be misleadingly low in patients with hypermobility affecting mostly large joints. So now that we established hypermobility as the first criterion for hypermobile EDS, what's next? We look at our algorithm and move on to the next step, which leads us to the additional criteria needed to establish a diagnosis of hypermobile EDS. So these are in fact 2 steps in our algorithm. The first step establishes the extra-articular manifestations needed for a diagnosis of hypermobile EDS, which corresponds to criterion 2 of the hypermobile EDS diagnostic criteria. And the second step rules out other causes of hypermobility, which corresponds to criterion 3 of the hypermobile EDS diagnostic criteria. And so here is a summary of the diagnostic criteria for hypermobile Ehlers-Danlos syndrome. The clinical diagnosis of hypermobile EDS needs the simultaneous presence of criteria 1, 2, and 3. Those are summarized in the table here on the right, which is admittedly difficult to read on the screen, but it's available in the PDF version of this practical guide. This diagnostic checklist is also accessible on the website of the EDS Society from where it was derived, and the link to the EDS Society is given here as well. Now, I just go through these criteria, and the first criterion, of course, we already went over in detail, and that's establishing the presence of generalized hypermobility, so we don't have to discuss this anymore. Let's go to criterion 2, which actually encompasses 3 different groups of criteria labeled as features A, B, and C. So feature A lumps all the systemic, or perhaps better, extra-articular manifestations, those affecting skin and tissue, skeletal system and teeth, and cardiovascular system. Now, the important take-home message here is that any of these manifestations would be mild. Severe organ manifestations in any of these categories should prompt you to consider other diagnoses than hypermobile EDS, and make you perhaps consider other forms of EDS. So, for example, severe skin hyperextensibility with severe atrophic scars would raise suspicion of possible classic EDS. Or significant progressive aortic root dilation would require evaluation for a thoracic aortic aneurysm syndrome. Then feature B. So feature B covers the family history. Hypermobile EDS is considered an autosomal dominantly inherited disorder, although there may be reduced penetrance. It's not uncommon for the parents to have features of or have had features of joint hypermobility in childhood when specifically asked. Sometimes this is volunteered when, and perhaps even one reason why the family consults you, but sometimes you actually have to specifically ask for that, especially if in adulthood the parent is not hypermobile anymore, or at least not doesn't have any problems with it, so may not think of it, but maybe in childhood this parent or one of the parents may have had hypermobility. Then feature C, and that covers the complications from joint hypermobility. A common and perhaps one of the most debilitating features of hypermobile EDS can be musculoskeletal pain, which should be present in 2 or more limbs, recurring daily for at least 3 months, or be chronic and widespread for at least 3 months. The other aspect is recurrent joint dislocations or subluxations, which are frequently unprovoked or at least associated with inadequate trauma. So let me say a few words about skin hyperextensibility, which is part of the feature A in criterion 2, if you remember. Cutaneous hyperextensibility refers to the ability to stretch the skin beyond the normal range. And then when the skin is stretched upon release, it recoils back to the original shape as the elasticity of the skin is retained. And that's different, for example, from skin looseness, where you have very loose skin that might actually stay where it is, or might be redundant. If you have that, you would think more of a different disorder, for example, cutis laxa, which we will not discuss here today. But like skin softness, hyperextensibility can be difficult to assess in infants because of the relative increase in subcutaneous fat. And skin hyperextensibility is most accurately assessed by gently pulling the skin at the volar part of the forearm, best where there is not a lot of hair, or perhaps the wrist until resistance is met. And it's best, on the other hand, to avoid testing at the extensor, so the outside surfaces of the joints, where there is often excess skin. And if the skin can be stretched more than 1.5 centimeters, this indicates hyperextensibility. And it's worth noting that skin hyperextensibility characterizes most EDS types, but the presence and severity are quite variable in hypermobile EDS. Now, when I say most EDS types, an exception is vascular EDS, which has noticeably translucent skin with visible veins, but not so much hyperextensibility. Another feature that may be present in hypermobile EDS to a variable, albeit again typically milder degree, is atrophic scarring. So this manifests in thin, widened tissue that spans the previous wound and has lost its normal pigmentation and patterning, as shown in the upper photo. Atrophic scarring is frequently associated with delayed wound healing, and we sometimes describe these scars as cigarette paper-like. There is some overlap with tissue fragility, and severe tissue fragility is really not a characteristic of hypermobile EDS, but it's a prominent feature of other rarer forms of EDS, such as classic EDS or vascular EDS. In these connective tissue disorders, the atrophic scars may be more extensive and complex with loculations, for example, bullae and surrounding loose skin, as shown here in the lower photo. And to close the review of skin features, I'd like to briefly mention piezogenic papules. Piezogenic papules are fat herniations through the fascia of the heel. They are typically not visible when the patient is supine, but become noticeable when the patient is standing on his feet. Piezogenic papules are not specific for hypermobile EDS, and they occur in the general population. However, when present in the context of hypermobility, they can be used as a connective tissue feature. So patients with hypermobile EDS frequently experience a myriad of symptoms that appear to be more commonly present in this group. But those symptoms are not part of the hypermobile EDS diagnostic criteria. And that's because there is simply not enough data for them to become diagnostic criteria at this time. While they are associated with hypermobile EDS, they are not proven to be the result of hypermobile EDS, and they are not specific enough to be criteria. So some of those include sleep disturbance, fatigue, postural orthostatic tachycardia or POTS, functional gastrointestinal disorders, dysautonomia, anxiety, and depression. These conditions indeed may be more debilitating than the joint symptoms. They often impair daily life, and they should be considered and should be treated. Now, confusingly, there can be an association with autoimmune disorders and hypermobile EDS as well. Therefore, a diagnosis of autoimmune rheumatologic disorder, for example, may not completely exclude the diagnosis of a connective tissue disorder and vice versa. So to meet criterion 3, you need to consider and rule out to a reasonable degree other causes of hypermobility, hypotonia, and chronic pain. And that is in the guide. This is alluded a little bit more in detail, but the point is that it's also a reminder that hypermobile EDS is an exclusion criteria diagnosis to some extent. So one group of these disorders that I just mentioned that fall into this category is the clinically and genetically quite heterogeneous group of rare genetic conditions with increased risk of vascular complications. But this can be challenging in some cases, and if suspected, should prompt referral for consultation. And examples include vascular EDS, Marfan syndrome, or the related group of Loeys-Dietz syndrome or homocystinuria. And then there are several non-connective tissue disorders with presentations that overlap with hypermobile EDS. These include neuromuscular and myopathic disorders, gastrointestinal disorders, allergic or immunologic disorders, and also the large group of chronic pain and chronic headache syndromes. Some congenital myopathies may feature joint hypermobility and skin changes, and I give a few examples here. Now, congenital myopathies more often show distal rather than generalized hypermobility. So, for example, the distal and proximal interphalangeal and metacarpophalangeal joints of the hands, the distal interphalangeal joints of the feet, wrists, and ankles. And those are also, so these congenital myopathies are frequently accompanied also by congenital hip dislocation, and that's especially true for collagen 6 related disorders and RYR1 related conditions. Now, collagen 6 related muscular dystrophies have prominent and aggressive joint contractures, typically occurring in the shoulders, the elbows, hips, knees, and Achilles tendon, but also in the finger flexors. So basically look for evidence of joint hypermobility as well as contractures in the hands and fingers in these disorders. Functional GI disorders are also quite common in hypermobile EDS and may include GERD, delayed gastric emptying, and irritable bowel syndrome. Fibromyalgia and chronic fatigue syndrome may present with overlapping GI symptoms. Celiac disease may coexist with hypermobile EDS or be misdiagnosed as EDS. Common features in this group of disorders include, or they may include pain, fatigue, functional GI problems, and also cardiovascular dysfunction, so there may be overlap. And in younger patients, chronic abdominal pain, feeding intolerance, poor growth and failure to thrive, severe constipation may be the presenting complaint and may warrant a pediatric gastrointestinal evaluation. So these are rare situations, but if you have this presentation and you don't have an etiology, it's something to consider because it needs appropriate management. Also, multiple food allergies leading to eosinophilic gastrointestinal disease is another commonly associated problem in pediatric patients. And then mast cell activation disorder, that is associated or is thought to be associated with some of the systemic symptoms of EDS. It's, I think, important to realize that there are some, as some of you may know, there are some laboratory tests such as serum tryptase level and N-methylhistamine in urine, but those are notoriously insensitive and should be ordered and interpreted by a specialist familiar with the condition. This also needs to be differentiated from mastocytosis, which requires biopsy evidence. In addition to chronic hives and rashes, mast cell disease can also involve the GI tract as well as the bladder, so it's important to keep in mind. Now, chronic pain unrelated to joint dislocation is very common in hypermobile EDS, and there may be overlap with fibromyalgia or chronic fatigue syndrome. But it's important to remember that most patients with fibromyalgia or chronic fatigue syndromes do not have hypermobile EDS. Chronic headaches, including migraine and tension-type headaches, are common in hypermobile EDS, and there is some evidence, albeit limited, that suggests that Chiari-1 malformation and occipito-atlantoaxial instability may be more frequent in patients with hereditary connective tissue disorders, including with hypermobile EDS. Although the clinical relevance of this potential association is uncertain at this time, so there's still more research to be needed. So if you have a patient with chronic headache involving a neurologist specializing in headache management might be helpful, as would be referral to a formal pain consultation team as well. So now that we established a diagnosis of hypermobile EDS in our patient, what's next? Management and referral. So we will cover some questions revolving around management and referral here. And because referrals are important elements of the management, and given that your referral practice will vary with, depending really on your experience and practice setting, it is reasonable to address both management and referral questions here together. But there are some generally recommended evaluations and interventions. Echocardiogram. We need to evaluate the structure and function of the heart, including mitral valve prolapse and for aortic root dilation. Eye exam to detect abnormalities associated with connective tissue disorders. Orthotics, if the child has flat feet with ankle pronation. So this will help to realign ankles, feet, and knees and hips, and may improve lower extremity pain and also fatigue. Physical therapy, very important. If the child has joint hypermobility, history of dislocations or subluxations or joint pain. The goal here is to increase muscle strength and to stabilize joints, as well as to improve overall physical conditioning. Physical therapy on a regular basis really should be the mainstay of pain intervention. Occupational therapy for complaints of pain and fatigue in hands, for example, affecting handwriting or other activities that interfere with, with school or activities of daily living. And then, in that regard, it might be worth to think about possibilities to modify the school program, including a 504 plan, which may be a very helpful recommendation for a school-age patient. So this can include use of computers, shorter writing assignments, freedom to drink more in school or use the restroom when needed, and really also giving more time to complete assignments. Now, here's a list of more targeted evaluations and interventions that may be indicated with specific presentations. GI consultation may be indicated if there is significant abdominal pain, nausea, bloating, constipation, especially if it affects the child's ability to eat or drink normally, which then can contribute to dizziness, headache, and other symptoms of POTS, for example. Also, failure to thrive, as mentioned earlier, may be a problem in more severe cases, and also symptoms of GERD. Also, as mentioned earlier, multiple food allergies can be coexistent in patients with connective tissue disorders, including eosinophilic esophagitis. A urologic consultation, functional symptoms are present, including frequency, urgency, enuresis that are not associated with urinary tract infection. Also, in this setting, you may consider a referral to a physical therapist who's knowledgeable about pelvic floor issues and exercises. And then psychotherapy is a very important consideration. It's estimated that 70% of patients with joint hypermobility and joint pain have a coexisting anxiety disorder. And there's a strong, so to speak, neuroconnective phenotype that requires a multidimensional approach to care. Now, this aspect of care cannot be ignored and really should be, and therapy should be initiated as early as possible. If you have access to a multidisciplinary pain clinic, this may be a good option if pain is really a limiting factor in participating normal activities of daily life, such as school and social activities. And ideally, this will include physical therapy and psychotherapy as part of a multidisciplinary clinic. Physical medicine or physiatry, rehab medicine can be very helpful to oversee the overall medical management of complex patients, to which sometimes EDS patients belong. And then a sleep evaluation may be something to think about if the child is having trouble falling or staying asleep and is chronically fatigued. So poor sleep and fatigue are associated with increased pain and anxiety, and poor sleep hygiene is often the biggest contributing factor. Also, just to mention this here, sometimes low iron stores can be a contributing factor. So checking your ferritin level and repleting iron might be indicated. And then an allergy evaluation might be helpful. needed in certain circumstances. So for mast cell activation syndrome, if the child has unexplained rashes, hives, or perhaps even symptoms of anaphylaxis with unknown etiology. Mast cell infiltration can also cause or mimic GERD, and it's often difficult to distinguish from GI manifestations of EDS. On the other hand, mast cell activation syndrome may also involve the bladder and cause symptoms which may mimic recurrent UTIs. The diagnosis of mast cell activation disorder is quite difficult and may warrant really a formal testing by an immunologist or, depending on what symptoms are, a urologist with expertise in patients with EDS. Now, many patients with joint hypermobility and EDS also have autonomic dysfunction with abnormal regulation of the involuntary nervous system, and that's made worse by decreased physical activity and overall physical deconditioning. Associated symptoms can include dizziness, tachycardia, syncope, headache, nausea, digestive issues, foggy thinking, brain fog, and an anxiety. And orthostatic vital signs are helpful in the diagnosis. So for teenagers, the criteria for this diagnosis is met if the heart rate increases by 40 beats per minute after changing position from lying to sitting to standing. And the patient should be lying for at least 10 minutes before checking blood pressure and heart rate, and also wait 2 minutes after position change from lying to sitting and from sitting to standing to check the blood pressure and heart rate to obtain accurate results. Now, in contrast, the frequently cited tilt table test, sometimes cited also as gold standard, is not needed in most situations and is difficult to perform, also has a high rate of false negative results. So that's frequently not necessary, really. Now, the mainstay of treatment of dysautonomia in hypermobile EDS are increase of water intake and intake of salty snacks. Fluid intake of 1.5 to 2 liters per day, and extra salt in the form of salt tablets or other salt additives may be required. Now, rarely more intensive management is needed, and if so, may include medications or IV fluids, even to the point of requiring a central line placement. If it comes to that, really, this should be guided by a specialist knowledgeable in dysautonomia management. And another important aspect is physical therapy, with a physical therapist ideally familiar with joint hypermobility and POTS. The Levine protocol is recommended for a slow and gradual increase in physical activity to improve conditioning. The link for the protocol is given here as well. Now, lastly, when should you refer? Here are some general guide points. If the patient meets diagnostic criteria for hypermobile EDS and presents with mild to perhaps moderate symptoms, the diagnosis and the management can be through the primary care provider, as we outlined in this webinar. Now, if you are not comfortable in assessing joint hypermobility using the Beighton scoring system, or simply don't have enough time, a physical or occupational therapist may be helpful in performing this assessment and determining perhaps also if the patient might benefit from therapy. Now, if a patient presents with severe symptoms, so for example, multiple recurrent dislocations, severe skin manifestations, severe GI problems, or severe dysautonomia that doesn't respond to regular treatment, or perhaps with atypical symptoms like progressive aortic root dilation, for example, specialist consultation may be needed or may be at least considered. So our practical guide includes 2 tables that address possible indications in more detail for possible indications for specialist referrals in more details. And those tables are organized by organ system and by type of specialist. So you can consult those tables. And then finally, this practical guide was a team effort, and I would like to acknowledge the MSRGN leadership, Elias, geneticist and medical director of the special care clinic at the Children's Hospital of Colorado, and also, of course, all the professionals, colleagues, individuals and families who assisted in the review of these documents. The documents that are on our website and the documents that were also the basis for this webinar. And so I end with thank you for watching and wish you a great day.
Thank you so much, Dr. Elias. That was an amazing presentation. You have shared so much knowledge and so many good tips for all our primary care providers in the audience. So we are excited to go to questions. We have about 10 minutes left, and we have had quite a few that have come into the chat. So let's go ahead. Before I do that though, we're gonna just drop the link to the evaluation. There are a couple people that have let us know that they have to duck out early. So we'll drop the link to the evaluation in the chat box. And this evaluation is both for CME CEU credit and for non-CME CEU credit. So it gives you an option to say if you're claiming credit or not, but we would love your feedback and the evaluation filled out by everyone who attended. So take a peek for that in the chat box. And then I'm going to go ahead and moderate some of these questions that have come in, and Dr. Elias, I will let you answer them. So one that came in was, would you consider subluxation of ribs to be some kind of connective tissue EDS manifestation?
Yeah, so subluxation of ribs. So the short answer to that would be not primarily, not if it's isolated. So subluxation of the ribs is kind of a not very well defined syndrome. It's also used sometimes referred to as slipping rib syndrome. Usually it's painful. It's usually associated with some kind of trauma, even if it's not recollected, either a direct trauma or even certain sports, swimming can do it and so on. So if this is something that's isolated with no other signs of hypermobility, I would not use this as a criteria, nor would it, and it can be, it can be quite painful. So this can be a really difficult, and it needs, sometimes it takes a while to really treat. But if this is isolated and no other manifestations, I wouldn't primarily use it, for example, as a need for an EDS workup. Now, if a rib subluxation is part of a larger phenotype, then you would have to include it in the, I would include it in the differential diagnosis.
Great, thank you for answering that. We have another question here on what is your view on the efficacy of glucosamine and chondroitin supplementation for patients with hypermobile EDS or other hypermobility disorders?
Well, so, okay, so I think there are two parts to that question. Chondroitin sulfate or glucosamine chondroitin sulfate is primarily used in the treatment of osteoarthritis. And the question here, the primary question for me is, what's the evidence for its efficacy actually in osteoarthritis? And we don't need to go into that, but when you look at large studies that have been done, there are a lot of anecdotal smaller studies that have looked at that, and they actually indeed have shown an improvement in certainly, especially in pain and stiffness. But the fact is that when you do larger studies, including meta-analysis of other studies, and look at high quality studies, that becomes questionable how helpful it is in osteoarthritis. Now, using this, I would not recommend it. I don't think it has a place in hypermobility per se. Now, especially in adults with significant hypermobility, they might develop premature osteoarthritis due to recurrent dislocations and subluxations, and etc. And so, if you to treat symptoms related to that, for example, joint stiffness and joint pain, I think that's an option, especially if otherwise options are limited. So I think it's something to discuss with the patient in that realm, but not for, I would not use it for hypermobility per se, especially not in children, where there's no evidence for joint degeneration.
Great. And the next question we have here is, when evaluating hypermobile EDS, there are a large number of patients who have chronic aches and pains, but have a positive Beighton score. But when should you do a cardiac echo in this large group of patients to assess for aortic root dilation, to assess for criterion 2? So I think you did cover this a little bit later, but maybe you want to expound on it.
Yeah. So first of all, there's, everything we discussed today, the problem is always a little bit that there are no clear guidelines, okay, when to start this. However, what I would say is this: if you make a diagnosis, so as a guideline, as a guide point for you, if you make a diagnosis of hypermobile EDS based on the criteria, I think it is reasonable to do a baseline echocardiogram. Mild aortic root dilation is found in, depending on what you look at, 10 to 30% of individuals with hypermobile EDS. Now, in hypermobile EDS, this is not progressive. It's benign, essentially. It does not have the dynamic of other connective tissue disorders, particularly Marfan syndrome and Loeys-Dietz syndrome, for example. So the reason then the rationale to do an echocardiogram in these situations, so as a, if you will, as a baseline, or really after a diagnosis, is to ensure that there is no significant aortic root dilation. If there is significant aortic root dilation, or if there is aortic root dilation, you might actually follow this up, or it is progressive, you would have to question the diagnosis of hypermobile EDS, and you would think of other differential diagnosis primarily, and that's really the main indication here. So it rarely is aortic root dilation in hypermobile EDS significant enough that, or it's usually not progressive, at least not grossly progressive. So I personally, if I make a diagnosis, so the question was aches and pains and hypermobility. If you just have a child, for example, or a teenager or an adult with hypermobility and chronic pain, but really doesn't meet criteria for the diagnosis of hypermobile EDS, I would be, I would perhaps look at other information. For example, family history. Is there a family history of cardiovascular disease? Is there a family history of aortic aneurysm, for example, unexplained early death, for example? So I would try to use other additional information to narrow that down. Whereas if I make a diagnosis of hypermobile EDS, I usually get an echocardiogram. And I tell the patients, the families, this is, we do not have to follow this. If it's normal, there's no reason to continue this.
Great, thank you. And there's a piggyback question to that, one that you just answered. For which patients would you send genetic testing to rule out the life-threatening forms of connective tissue disease? With no gene described for hypermobile EDS, most families still want to rule out vascular EDS.
Yeah, so this is also not like with EDS in general, not a question that you can pinpoint very clearly. I think there are two aspects to that. Number one, genetic testing has become, increasingly available. It is not as expensive anymore, although gene panels still are relatively expensive, and we have to say that. But there are gene panels readily available. So it's not a it's doable to do a comprehensive gene panel that excludes these, well, that addresses these conditions. On the other hand, I don't think that and we're talking really about patients that you see in the primary care quite frequently, patients with hypermobility. Not every child or every patient with hypermobility needs a gene panel to exclude those conditions. And so what are those life-threatening conditions? Vascular EDS is certainly a consideration. And so if you have a child, or and the important thing there is that with vascular EDS, the vascular complications do not show up until do not develop until later in adulthood. However, most patients with vascular EDS have some skin manifestations. The joint manifestations, as I mentioned that a little bit in the talk, if you have a patient with clearly large joint hypermobility and otherwise, and perhaps chronic pain, perhaps mildly soft, perhaps velvety skin, but no signs of tissue fragility, significant atrophic scars, for example, I don't think that this patient necessarily needs genetic testing. However, some patients with hypermobile EDS, they do have atrophic scars, for example. They are usually not as I showed that a little bit in the talk. They're not as extensive as in classic EDS, for example, or vascular EDS, but they are not readily discernible. So if I do have significant skin manifestations, I usually do genetic testing. Similarly, if you have aortic root dilation, I would do genetic testing. And if you're not sure, and so I'm speaking for myself now, as you know, one reasons why we're doing this webinar is really to empower and you as primary care providers really to kind of go that step further. And we know that it's difficult to get patients into, for example, genetics departments to be seen. But I rather would be called and asked or emailed also with a question, do we need a genetic testing there, than just do genetic testing without a good rationale to do that, because you always have to think also about variants of uncertain significance that you will find that might actually add to the confusion. What's important is, if you do genetic testing, to be very clear with the family what you're testing for, and also be clear that you are not ruling out or ruling in hypermobile EDS.
Great answer, thank you. We are at the top of the hour, just a little bit after. Do you have a moment for one or two more questions?
Yep. Yeah.
Okay, sounds good. So there is another question about, is there any connection with tethered cord or tongue tie and EDS?
Yeah. So the tethered cord, the tongue tie, I'm not aware of that. Tongue tie is very common. It's probably overdiagnosed and overtreated, but that's but the question is tethered cord. So that falls into this complex of Chiari-1 malformation, syringomelia, tethered cord, so some patients with Ehlers-Danlos syndrome, including hypermobile Ehlers-Danlos syndrome, do have symptoms of tethered cord. Some have actually structural abnormalities. There's even something like occult tethered cord syndrome, and so I think what's important there is to look at the symptoms. And the reason why this is important, and it's a really good question, is that some patients, and I mentioned that in the talk, who have hypermobile EDS, they have bladder dysfunction, for example. Some have GI problems, chronic constipation. Some have chronic lower extremity pain, weakness. What is this? These are all manifestations that can be in tethered cord. So if you have a child or a teenager who has a lower extremity weakness and hypermobility, and for example, potentially a neurogenic bladder, I would think about that. You should think about it independently of the EDS workup as well, but one should know that I think Tetrad coat is not a common symptom, not a common disease complex in hypermobile EDS or in EDS, but it is described, and how frequent it is, I don't know, but it's important to think about it. If you have the triad, it's really a triad of symptoms of Tetrad coat, you should look at it. I hope that kind of covers
Great,
it.
and I think we have time maybe for just one more, if we can squeeze one more in here, and then we'll wrap up. This is from one of our colleagues in Colorado. In our experience, the vast majority of adults better fit into generalized hypermobility spectrum disorder diagnosis and fall short on meeting the sufficient criteria for hypermobile EDS. Does this align with your experience?
Yeah, I'm probably not the right person to ask to ask this. And I might be some specialists and experts might not agree with me, but I really think hypermobile EDS is a very heterogeneous condition. It has phenocopies. It's genetically heterogeneous. So the important thing for me as a geneticist, I think, is to realize that all of the studies that looked at rare highly penetrant mutations with large studies, so exome sequencing, did not find a single gene that would explain this. There are GWAS studies that show that indicate that there might indeed be kind of a polygenic contribution, and what likely is the case is that both rare variants that can cause, that there are certain rare variants, and much more common low penetrance variant can cause hypermobility in general. I'm looking forward perhaps at the idea of perhaps at someday have a polygenic risk score to look at that. We're not there, but there are some larger studies GWAS studies that indicate that this is a possibility. And in this situation, I think it is semantic to distinguish, and I don't think it helps us with management if we make this strongest. So I'm more of a lumper there in that. So I would agree.
Great. And with that, I just want to thank you again so much for your time, your effort in leading our work group, as well for creating the algorithm. And just want to bring up this last slide here to remind everybody, we have put in the chat a couple of times the link for the evaluation for CME and CEU credits. Those credits will be processed in the coming weeks, and you will be receiving an email with a link to download your certificate from our partners at Projects in Knowledge. With that, just another reminder that if there's any pediatric or primary care providers out there that would like to be part of this initiative that this webinar is part of, this education program, in our next cohort, our applications are due Monday. And so you can scan that code and submit that. And if your question was not answered by Dr. Elias today, or you have additional questions, you are free to email me and I will pass those along. Dr. Elias has graciously said he will answer some of those, just not hundreds of them, but I think a couple. He's happy to get back to you. So feel free to send those to me and I can get those to him. But again, thank you, Dr. Elias, for all of your efforts in putting this together for us today. And we thank you all for joining us for the Time for Genetics webinar. Our next webinar will be in May, and the topic will be genetic testing. Until then, we will talk to you later, and thank you again. Bye-bye.
Yeah, thank you. Bye-bye. Thanks for great questions.